Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Do you or a loved one suffer from chronic long-term COVID? Find out more right now. My guest this evening is Dr. Sattah, a specialist in management and treatment of long COVID. Anna,
Hi.
Welcome to Housecall.
It's nice to meet you. Thanks for having me.
My pleasure. So briefly tell our viewers about your professional background.
Well, I started in conventional medicine, and I went to medical school and then residency in general surgery. And I did a fellowship in critical care, and then I was practicing in the ICU at Holy Cross up through 2022. And that included all through the COVID pandemic. And we started seeing how limited some of our treatments were once people got into the ICU. And I started looking more and more about other ways of supporting patients. And that's what got me into functional medicine, and then ended up completely shifting. And so now I'm a full-time functional medicine doctor.
Good for you. It's certainly a vacuum out there for patients to find somebody who has an interest and expertise. So it's an important addition to Montgomery County public health options. Yeah. So I've already used the term several times, long COVID. Mm-hmm. Would you please define for our viewers what exactly that is?
So it's kind of a general classification. Really, they're just referring to patients who get a COVID infection and then they have symptoms that last at least a month. Some definitions say at least 1 month, some say 3 months. In my mind, it's usually at least 3 months or so, where their health really changed and hasn't gotten back to baseline. And for some patients, that can last for several months. I've had some patients where that has been going on for years now.
Oh my. So how common is long COVID?
It is relatively common. I think the severity ranges a lot, but there's some estimates that at least 3% of the population, or of the adult population, has long COVID, or more than 7 million Americans. So it's a lot of patients, and then it's just a matter of how severe is it for some people.
You mentioned 3%, that's of the overall population, mm-hmm. But if you take 100 patients who have COVID, mm-hmm. What percentage go on to chronicity, long COVID?
It's hard to really say because so many people have had COVID multiple times. Mm-hmm. And so if you're going back and saying, well, how many times might you have had a virus, and did you know if it was COVID or not? And if you're looking back now at almost 4 or 5 years worth
Sure.
of exposure, it's the majority of the population. But I would say a couple of percent, maybe 2 or 3%, seem to have really significant persistent symptoms.
Okay. So what are some of the most common symptoms for patients who suffer from long COVID?
So fatigue is really common, and fatigue can be energy, like you just don't have energy to get up and go and do what you want to do. But it can also be difficulty concentrating, brain fog, trouble sleeping, changes in GI function and abdominal discomfort. A lot of people have food sensitivities that they didn't used to have, or they have histamine reactions where they'll be eating foods and they're reacting to them, or they're starting to get allergies and hives. We also see a lot of people that have problems with the autonomic system. Mm-hmm. And so just their body regulating nervous system function, like maintaining their blood pressure when they stand up rapidly.
I know many patients, unfortunately, have difficulties with smell and mm-hmm. taste.
Yeah.
Why do you think that is?
Well, I think the nerves that are going to the brain, the olfactory nerves, are demonstrating that there is a neuronal component to this, and that the COVID virus is affecting those nerves. And that's a really specific one that we can measure, because people can notice loss of smell. And it's also direct connection from the nose and where you're breathing things in straight to the brain. So it's a very short distance to get to the brain.
Sure. So you mentioned your prior training as an ICU physician. How do you think that background shaped your interest in this topic?
Well, in the ICU, we're always looking at kind of multi-system approaches. And if somebody comes in and they're in multi-system organ failure and they're admitted to the intensive care unit, you're coming up with plans to address all those systems. And I think COVID and long COVID are similar because they're affecting a lot of different body systems, not to the point of putting you in the hospital, but I feel like you do need that same comprehensive approach to try to support those patients.
Now, how do you diagnose long COVID? Is that just a clinical diagnosis, or are there specific laboratory tests?
For my part, I use it as a clinical diagnosis, and it's mostly based on the history when I'm talking to patients. There are a couple of tests that are out, one of which looks at cytokine production, and it's looking for abnormal cytokines, which are these inflammatory chemicals that the body produces, and there are certain patterns that are associated with persistent infections or persistent symptoms from COVID. So that's one test. There's a new test out of Germany called the Atomaker test that's looking at changes in antibody spectrums, and they're looking at specific antibodies against different different strains of COVID, on whether or not the body is producing appropriate antibody responses. So that's a fairly new test that I think is undergoing FDA approval at the moment.
How interesting. Now, is it fair to say that patients with long COVID do not have detectable virus in the blood?
I would say they most likely don't have replicating virus, but a lot of people have some sort of viral debris. And whether that debris can be remnants of the virus, it can be remnants of spike protein that can be tested for. A lot of those tests, though, are like laboratory-based tests and not necessarily in the clinic.
Right.
And so I don't have a great diagnostic test that's kind of commonly recognized to diagnose.
So what are your thoughts why a single virus like COVID can cause such a diversity of ongoing symptoms? Why is it long COVID varies from one patient to another?
Yeah. So if you imagine 100 people who all got infected by COVID, and 90% of them are better in 2 weeks, and then there's a handful of them that have symptoms that last for a couple of months, and there's a few that have symptoms that last for years, I feel like that in part is based on what's different about those patients at the time that they got infections. And so one of the factors is things like vitamin D levels and underlying inflammatory stressors, ability to handle oxidative stress. Those things can affect their ability to recover. But the virus itself also gets into the cells using the ACE2 receptors. And we have ACE2 receptors on all sorts of tissues in the body. So we think of ACE2 receptors in the lung, and we think that's where the lung issues come from. But they're in the kidney, they're in the bloodstream, or in the blood vessels, they're in the pancreas, they're in the liver, they're in muscle cells and heart tissue. And so if you have a virus that can infect all these different kinds of tissues, you can have really broad-ranging effects. And the vascular side of it, I think, is really important, because if it attacks the lining of the blood vessels, every organ in your body has blood vessels. And if that area is inflamed, then you're going to have really substantial symptoms downstream. And I think that's also kind of why we had such severe symptoms with acute COVID, because we were seeing vascular inflammation that patients couldn't turn off, that was impacting their kidneys and their lungs and their brain. And so.
Do you have a sense that genetics plays a role here?
Yeah.
That the different presentation for long COVID, as it does vary from patient to patient, that there may be different genetic susceptibility?
Absolutely. So we were talking about blood vessels a minute ago, and one of the things that can happen is, if the blood vessel lining is a little irritated, it can cause your body to be prone to clotting. And some people are more prone to clotting than others. It doesn't necessarily mean they have a disease, but there's a spectrum of how rapidly people clot or don't clot, or how rapidly people break down clots. And so I think that kind of thing can have an impact. There are also differences in the way people clear toxins, like the enzyme systems that allow your body to eliminate toxins or that allow your body to deal with oxidative stress. And so that's a big variant. And we've started doing genomics recently and looking at variations in inflammatory responses. And for example, if somebody is very prone to producing IL-6, that's an inflammatory cytokine.
Interleukin.
Yep.
Right.
That, you know, and then that person has a trigger, they're more likely to have an overblown response. And my suspicion, if we were running genomics on all these patients, is that there probably is a significant genomic impact, but it's probably not one gene, like you have this one gene and you will get long COVID. I don't think it's that. I think it's just that there may be more people, or there may be some people more prone to inflammation, less prone to it, that type of thing.
Do you think there is variation within the COVID virus community, that some are more likely to trigger long COVID than others?
Yeah, absolutely.
Yeah.
Absolutely. They've done some genetic trees of the virus as it's mutating,
Yeah.
and you can watch this strain and it explodes into a whole bunch of mini strains, and then one of them will be the dominant strain and it will explode into a bunch of strains. And so that has been changing ever since the virus was identified in 2019.
Right.
And you kind of have to think of it as individual viruses. It's not, I mean, we use the word long COVID, or we just call everything COVID, but it's a different virus each time. And sometimes there have been strains that have come out that have had more GI symptoms, some of them have had more pulmonary symptoms, and it makes sense to me that they would have different implications as far as long COVID too.
You mentioned at the top of the interview that fatigue is a prominent part of the presentation of long COVID.
Yeah.
What do you think is the mechanism for that fatigue?
I think it's a couple of things. One, I worry about mitochondrial dysfunction, and
explain for our viewers who
Yeah.
don't have a background in science what exactly are mitochondria.
Yeah, so mitochondria are like the powerhouses of the cells.
Okay.
And every cell in your body has mitochondria. So the skin cells and the heart cells, the liver cells, but you can imagine like your heart that's beating all the time is going to need more mitochondria, more energy than my skin cells would. And your brain needs a ton of mitochondria. And the mitochondria themselves are susceptible to damage, and they're not necessarily great at repairing that damage. When people have a lot of oxidative stress, which is kind of like, it's the same process as rusting. Or if you cut an apple and it turns brown, that's oxidative stress or oxidation reactions. The same thing happens in the body. And when we have an infection that causes this big or this oxidative stress, it can damage those mitochondria. And if those aren't being repaired, then you don't have energy. And so some people come in and they say their main symptom is fatigue, but for some people the symptom is they can't focus, or if they were trying to work really hard on some sort of cognitively challenging process, that brain energy of just thinking through something or following a conversation on Zoom, if there's 10 different people talking, it's mentally exhausting for them. Other people will describe this post-exertional malaise or post-exertional fatigue. And so it's kind of like the more they do, the next day they just crash because they used energy that their body didn't have.
Sure. Fascinating. We're going to pause briefly for a public service announcement. More with my guest, Dr. Anna Sattah, in a moment, and we're discussing long COVID. We'll be right back. We're back. My guest this evening is Dr. Anna Sattah, and we're discussing long COVID. Anna, when we paused for the break, we were discussing different aspects of long COVID. Let's go on to discuss briefly how long COVID affects the immune system.
So I think it hits the immune system in a number of ways. One of the theories about this is that the monocytes, which are a kind of white blood cell, almost like doesn't forget about long COVID or doesn't forget about COVID. And typically these are white blood cells that remember an infection for about 5 days, and then, after 5 days it's a moot point and they die. And there's some research that Dr. Bruce Patterson has done that shows that there's a population of these cells that just keeps persisting, and one of the theories is that is a component. I think one of the other mechanisms is that the body's relaxation response, or the vagus nerve, this section of the body that controls rest and digest, as compared to the fight or flight system, that system gets turned on, and so the body's stuck in this kind of hypervigilant state, and so you're always overreacting to everything, and that overreaction also impacts the immune system. And so that's another potential theory. And then one of the other concerns that I have heard is that COVID can affect the body's ability to produce effective antibodies, and that you're stuck producing antibodies against one strain that isn't a good strain, and then you effectively don't have the capacity to make the antibodies that you need against what you need to fight off right now. So I think that's kind of an open question, but there's a lot of research going on in that at the moment.
Sure. Now, another very interesting topic, particularly since I'm, as you know, a gastroenterologist, is there have been observations that long COVID may change the intestinal or gut microbiome, the bacterial population. So how does that happen, and what are the consequences of changing the gut microbiome?
So I don't think we know exactly how it happens. I know that there have been studies where they've looked at the populations of bacteria that are in patients before COVID and after COVID, and they're seeing a shift, and they're not seeing it come back to normal. So it's like some things changed, the ecology changed, and I think of the gut microbiome kind of like its own ecological niche. And so things are in some sort of balance, and if you upset that balance, it can get to a new balance that can be stable, but it doesn't necessarily come back. Just like I could take a rainforest, I could cut it all down and plant corn, and now I have a corn ecosystem, but that ecosystem's also stable. If I just go sprinkle rainforest seeds, I'm not gonna regrow a rainforest. And so we're seeing that shift happen. And then we also see changes, there's different transporters in the gut that transport amino acids, and those also get impacted by the COVID virus, and they affect the transport of large neutral amino acids. And so if you're not absorbing those amino acids, you don't have them as the building blocks for proteins. And these are building blocks for neurotransmitters and things like serotonin and melatonin. And so I think that's how we start to get mood changes and disruptions in sleep that really stemmed from changes that were happening in the GI tract.
How interesting, yes. So you mentioned earlier inflamed blood vessels, so-called vasculitis. So what role does inflammation in the blood vessels play in long COVID?
I think it plays a huge role, but I think it's variable. My sense is when patients come into me, all COVID patients don't necessarily look alike, but there are some patients that tend to have symptoms like really cold hands and feet, or when you look at their toes are a little bit purple and discolored, they don't have great perfusion. Some people who have kind of chest tightness and chest pain, but they've gotten cardiac workups and they've gotten CT scans and looking at their lungs, and they don't have anything visible on imaging, but they just have these symptoms. And I think that is likely related to very tiny clots in the capillary systems. And those are going to be too small to show up on imaging. But I think the patients that are more prone to clotting disorders, who have this this vascular inflammation are more likely to have those kind of microclots. And there are some labs, there's a lab in South America that has done some testing looking for those microclots. There's not a great test that I can order clinically, so it ends up becoming a hypothesis and a discussion that I have with patients, and then there's some treatments we can focus on. But that's the vascular side. And then I think there's also inflammation that's just being caused if there's a persistent reaction to either a virus or viral debris that hasn't fully cleared. And we talked before about what could cause fatigue and what can cause the inflammation. And if you have the flu and you feel crappy and you want to lay in bed and like not get up and move or anything, that's a normal response, and that's sickness behavior, and that's related to some of these cytokines that get released. And once they get released, they circulate in your whole body.
Right.
And so I think the same thing is happening. It's just that if you have those cytokines that stay around and they don't clear after a week, you keep having the symptoms, even though maybe the initial virus is gone.
How interesting. What has been the impact of long COVID in terms of people's ability to function on a day-to-day basis?
I think it really varies. I have a number of patients who have gone from really fit individuals like former Marines and CrossFit athletes and long-distance runners who are close to bedbound.
Oh my.
And they're young people, sometimes in their 30s and younger, and they get this virus and their body's just not recovering from that. Then we also see some people who have symptoms that are nowhere near as extreme, but it affects their ability to focus and concentrate, and they can't do their job. Or maybe they can't do their job at the level that they used to, or they can work for a day, but then the next day they come home and crash and they can't think and focus well. And so I've seen that very commonly.
Sure. How does long COVID with its fatigue compare to a alternative condition, chronic fatigue syndrome?
I think it's effectively the same process in the body.
Okay.
And when we describe the virus is an organism. It's just the virus. The way our body reacts to it is the disease or the syndrome or whatever happens. And so long COVID is kind of a syndrome, and it's a reaction to the virus. So chronic fatigue is a very similar reaction. We think that that's probably related to Epstein-Barr virus. And at least in some patients, it's Epstein-Barr, but it's not Epstein-Barr in everyone. And it's hard to blame it all on Epstein-Barr, because if you look at adults, probably about 97% of adults have been exposed to Epstein-Barr. So it's not just that you get the virus and then you get chronic fatigue syndrome, because most adults have had it. This is the thing that causes mono when you're in high school and college. And I think a number of viruses can cause these kind of post-viral fatigue syndromes, and some of them we have more information about than others. And what happened when COVID came out is it was a brand new novel virus, and so no one had ever had it until the pandemic. And then when all these patients started having a post-viral syndrome to something new, we put a new label on it and started studying it. But I think it's probably almost the same process as what's happening with other post-viral conditions.
So we only have a few minutes left, and of course the viewers want to hear, what are the treatment options at this time?
So it varies. I think if somebody's having autonomic dysfunction or POT symptoms, like their heart is racing when they're standing up, there are some cardiovascular medications. Avabradine has been very helpful for some of my patients. Nicotine patches have been really helpful, which sounds really bizarre.
Yes. Why?
But this is also hypothesis, but there are nerves in the body that use the nicotinic acetylcholine receptors. And these are the nerves that control this relaxation response. Oh. And we believe that some parts of the virus or viral debris can basically gum up those receptors. And then the receptors aren't transmitting the signals very well. And so now you're not getting great great signaling along that relaxation response, and that pushes people over into this chronic hypervigilant state, like the fight or flight system is always on.
Right.
And it looks like very low doses of nicotine through a patch, not through smoking or anything like that, but through a patch can help displace that. And then the body can flush those that debris away. And some of my patients do very well with a short course, some are on a longer course. I think it makes sense to titrate that really gently because I don't want to flush all that into the body all at once. But that's been very promising. If people are having GI symptoms, then looking at certain probiotics and like spore-based probiotics to rebalance the gut microbiome has been helpful. Fasting looks like it's been helpful for some patients. Anti-inflammatory diets have been. I think pacing is really important, which is just slowing down a patient's activity level so they're not constantly pushing themselves into these energy crashes.
Right.
Because those energy crashes are kind of digging a deeper hole.
Sure.
And so rest is really important. And then like nutrients that support mitochondrial function are important. But I could go on for a very long time.
I bet. Have you tried zinc for people who lose taste and smell?
I have done a little bit of zinc, but actually I have a patient who tried the nicotine patches. She had loss of taste and smell for 1.5 years, no change that whole time. And in a very short period of time that recovered, I won't say to baseline, but almost to baseline.
And now, that was from the nicotine patches?
Yeah.
How interesting.
Yeah.
How interesting.
Yeah.
So if our viewers have any questions, how can they reach you?
So my website is insightfunctionalhealth.com, and I have a lot of information on COVID and long COVID, and I've done a lot of webinars that go into some of the mechanisms and treatment options for that. So you're welcome to come to my website and take a look.
Thank you for a very informative interview.
Thank you. This was great.
My thanks to my guests for a superb interview on long COVID. My thanks to my team here at the studio. And of course, my thanks to you, the viewer, for joining us this evening. We look forward to seeing you for our next show. Dr. Stephen Correa, a noted pulmonary physician, will be discussing an update in lung disease and different important themes therein. See you then next time for another edition of Housecall. Good evening.